doctors. So today going to discuss about the liver cirrhosis, and I'm going to talk about our Mrcp basis consultation station. Liver cirrhosis is quite common case and it can appear in your consultation station as well as in your abdominal station. So I put there decompensated liver cirrhosis. Normally you will not get the patient who is very serious in your basis exam. I just put this heading so that you be more aware about the decompensated liver cirrhosis and rule out all important negative things. Okay, so let's move on. We talk first about the history. So this is a 65-year-old man and is brought by ambulance to the emergency department after his partner found him vomiting frank blood in the lounge. Paramedics reports multiple syringes and a strong smell of alcohol upon entering their home. Collateral history from partner reports that the patient has become increasingly confused over the past 2 weeks. Now, normally you will get the patient who is quite stable, but obviously because the consultation station, you have to take a full history. So that's why I put the important emergencies which can appear in the liver cirrhosis. So hematemesis actually is a medical emergency, and usually it originates from the upper GI tract, and the causes include esophageal varices. There can be other causes of hematemesis, include like Mallory-Weiss tears, it can be gastritis, peptic ulcer disease, or maybe vomiting ingested blood from ENT hemorrhage. So it is very important that the bleeding should be controlled to prevent the hypovolemic shock. So in this patient, the multiple syringes, this can indicate the patient may be an active IV drug user. And alcohol, over consumption of alcohol also can irritate stomach lining and causes gastritis. And there is a area prostrema, which is a structure in the medulla oblongata controlling vomiting, and it is activated by alcohol, triggering the nausea and eventually vomiting as the body attempts to get rid of the toxin. So increasing confusion in a patient with cirrhosis indicates the presence of hepatic encephalopathy. Most likely the patient will not be confused when you in your basis exam, but it is very important you must ask about the past history of any confusion episodes and hospitalizations. Other symptoms which can happen include changes in mood, personality, and movement in healthy individuals. The liver actually metabolizes nitrogen compounds, and these are which are produced by the intestinal bacteria. So what happens in patient with cirrhosis? This process is impaired due to reduced number of hepatocytes. So it causes accumulation of these nitrogenous products in the systemic circulation. And certain compounds such as ammonia, it can cross the blood-brain barrier where it is metabolized by astrocytes into glutamine. And the glutamine then in turn exerts the osmotic pressure, and this leads to an increase in cerebral edema and therefore confusion. And additionally, ammonia is also a neurotoxin and can influence other neural pathways with an imbalance between excitatory and inhibitory neurotransmission. Okay, let's move on to our history. His skin has become increasingly yellow, and his partner reports that he has been getting more swollen in the abdomen. So the presence of jaundice indicates an elevated bilirubin, and normally it is more than 3 mg per deciliter. And in cirrhosis, hepatocytes death reduces the ability to metabolize and excrete bilirubin, so leading to systemic accumulation. And then in addition to this portal hypertension, it can cause splenomegaly, and it also increases hemolysis and production of bilirubin. So swollen abdomen actually means that the patient has developed ascites, and the pathogenesis of ascites in patients with advanced cirrhosis is extremely complex, and it is caused by portal hypertension. So as the liver becomes increasingly scarred, there is structural distortion of the intrahepatic vasculature, so reducing the contractility of the hepatic vascular bed. And this is further exacerbated by reduced vasodilatory response and increased production of vasoconstrictors, and eventually leading to increase in portal venous pressure. So the splanchnic vasodilations occur with resultant systemic hypoperfusion, and this typically affects the renal function, leading to activation of the renin-angiotensin-aldosterone system in response to decrease in vascular pressure. Renin is secreted from the juxtaglomerular apparatus. So, together with an increased hydrostatic pressure from retained blood volume, this overwhelms the capacity of the lymphatic and peritoneal surface to reabsorb this fluid. So, it causes accumulation in the potential spaces such as the peritoneal cavity. And this abdominal distension from ascites may reduce the patient's level of appetite as well. His partner has also noticed that he has not been eating as much food lately and has been developing bruises on his arms spontaneously. Now remember, the liver is responsible for the production of numerous proteins, including clotting factors 1, 2, 3, 4, 5, 6, 8, 9, 10, 11, 12, and also fibrinogen and prothrombin. And the liver also synthesizes thrombopoietin, which is a hormone that regulates platelet production in the bone marrow. So when there is a damage to the liver from cirrhosis, it can impair coagulation, so leading to spontaneous bruising and bleeding. Okay, let's continue with our history. Over the past few months, she also reports that he has been suffering from erectile dysfunction. So very important, sexual history should be explored in cirrhosis of the patient. If the patient has cirrhosis, she also noticed that he has been leaving very offensive stools and dark red streak of blood in the toilet bowl. So patients with advanced liver disease, they often have low testosterone, which manifests clinically as erectile dysfunction, decreased libido, and testicular atrophy. In alcohol liver disease, ethanol also has a direct toxic effect on testicles. So what happens in cirrhosis? The pituitary production of luteinizing hormone is suppressed, and this is because of the elevated inflammatory cytokines like interleukin 1, interleukin 6, and tumor necrosis factor alpha that artificially downregulate gonadotrophin releasing hormone. We all know that melena is a black tarry stool that is extremely offensive due to enzymatic digestion of hemoglobin by intestinal bacteria. Most common cause of melena is peptic ulcer disease. Chronic alcohol consumption increases the risk of peptic ulcer development. And when combined with coagulopathy arising from advanced liver disease, can result in increased bleeding. His past medical history is positive for hepatitis C and alcohol liver disease. So remember, around 30% of the patient with untreated hepatitis C will develop cirrhosis. Globally, viral hepatitis is the leading cause of liver cirrhosis. An increasing number of patients with non-alcoholic fatty liver disease are also developing cirrhosis. Alcoholic liver disease is actually the second most common cause of liver cirrhosis globally and the leading cause in Western countries. And alcohol actually is a toxin and causes liver-related damage through steatosis, hepatitis, and eventually cirrhosis. She reports that the patient consumes an average a bottle of spirit per day. However, this has increased to 2 in the past month ever since he was fired from the job, and both of them are IV drug users. So sharing needles increases the risk of hepatitis, viral hepatitis, as the hepatitis B and C viruses are bloodborne. So that's all about the history, and as you can see that you have to take a focused history. It's very important to rule out the important negatives. Let's move on to the examination of this patient. So on examination, the patient is confused, not oriented to time or space, and unsteady on his feet. He has some weakness in eye movements. He's febrile, tachypneic, and tachycardic, and normotensive. As I told you that obviously in the PACEs, the patient will not be confused. This is just to get you more aware about the severity of cirrhosis. Confusion is a common sign of decompensated liver disease, and this can be attributed to hepatic encephalopathy. In case of alcoholism, patient may be deficient in vitamin B1, and which can also cause neurological impairment such as Wernicke-Korsakoff syndrome. Remember that Wernicke's encephalopathy triad comprises of ophthalmoplegia, confusion, and ataxia. However, this classic triad is present only in 10 to 20% of patients. So if the patient has fever, tachypnea, or tachycardia in the setting of decompensated liver disease, may indicate concurrent infection due to impaired immunity, accumulated endotoxins as the liver is unable to clear from the body, or in the case of active bleeding, hypovolemic shock. Peripheral examination reveals Palmer erythema and a positive hepatic flap. And you can see on the picture, on the top picture on the right side, I have put the picture for the Palmer erythema. So hepatic flap, it consists of infrequent involuntary flexion extension movement of the hand and is the result of neurotoxins such as ammonia impairing the diencephalic motor centers of the brain. Hepatic flap is not pathognomic for decompensated liver disease and may occur in uremia, hypoxia, and hypercapnia. So his nails are pale and contractures are noted on some of his left metacarpals. So I have put the picture for the Dupuytren's contracture here. And these are associated with the alcoholic liver disease. The exact pathogenesis is unclear. However, one theory suggests alcohol-induced damage to Palmer fatty tissues, provoking a fibrotic response. I have put another picture here of the Mrcp nails. These are actually pale transverse band extending all the way across the nail. And these are cutaneous manifestations of liver disease. And they are more specific for hypoalbuminemia. Okay. So once you're done, the important to do the hand examination, because hand examination you can have some positive findings like Dupuytren's contracture or Palmer erythema. Obviously going to check for the hepatic flap and look closely at the nails as well to see whether there are any brittle nails or spoon-shaped nail because of the iron deficiency, which can happen if the patient has been bleeding or Mrcp lines. Facial examination reveals scalar jaundice, a strong smell of alcohol in his breath, and swollen parotid glands. Examination of his neck and chest reveals multiple spider nevi. So remember that the enlargement, bilateral enlargement of the parotid gland, it may be secondary to malnutrition, liver disease, and alcoholism. Spider nevi, these are vascular lesions which is characterized by a central red spot with reddish extension that radiate outwards like a spider web. and they are generally found in the distribution of superior vena cava, such as the face, neck, arms, and chest. Okay, let's move on to the examination. Gynecomastia is also present along with patchy chest hair growth. His abdomen is extremely distended with superficial veins present and dilated. Palpation of the right upper quadrant is difficult, however the liver is hard with a nodular liver edge. So remember, estrogen levels are frequently elevated in men with cirrhosis due to impaired hepatic metabolism. Chronic liver disease, it causes a disproportionate increase in sex hormone binding globulin, which has a strong affinity to bind free testosterone than estradiol. And this causes an imbalance in free estrogen to androgen ratio, and clinically this causes gynecomastia and the development of a female body habitus. So, caput medusae is the name given to the appearance of dilated superficial epigastric vein, and you can see on the top, on the bottom right, I have put the picture for the caput medusae. And these veins radiate from the umbilicus across the abdomen, and it is caused by portal hypertension. So in most patients with no hepatic disease, the liver should not be palpable. Firmness and irregularity of the liver edge is often caused by cirrhosis, as scar tissue is much firmer than normal parenchyma. However, nodular edges may also be suspicious of neoplasm as it becomes infiltrated with cancerous cell. We can do percussion to map the size of the liver, which on average is about 7 to 10 centimeter. However, remember, in advanced liver disease and cirrhosis, the liver size reduces as normal parenchyma is replaced with fibrotic tissue. Splenomegaly is also present. There is no other organomegaly. So splenomegaly occurs in advanced liver disease due to venous congestion of blood in the spleen from portal hypertension. And the release of inflammatory mediators may also activate splenic lymphoproliferation of immune cells. Percussion note is resident and bowel sounds are muffled. Shifting dullness is also elicited. So shifting dullness indicates the presence of fluid in the peritoneal cavity. However, false positive can arise in patients with fecal loading and also in obese individuals. However, remember, this test is only accurate when there is more than 500 ml of fluids present. So that's all about the examination. So let's move on to the investigations for this patient. So first of all, full blood examination, we'd like to order full blood examination, which will reveal normocytic anemia, and we expect to see normocytic anemia and thrombocytopenia. Urea and electrolytes may have elevated urea, creatinine, and reduced eGFR. So LFTs are globally deranged with an elevated AST, ALT, bilirubin, alkaline phosphatase, and gamma GT. Hypoalbuminemia is confirmed along with a prolonged INR. Serum ammonia and alpha fetoprotein, they should be ordered. Hepatitis serology is positive for hepatitis C, but there are no other derangements on the liver screen panel. So anemia may be secondary to GI hemorrhage and iron deficiency, and thrombocytopenia can occur due to hypersplenism, which is a consequence of portal hypertension. Reduced eGFR and elevated creatinine may be due to hepatorenal syndrome, which is a complication of portal hypertension. LFTs, they are generally deranged in patients with cirrhosis with moderately elevated AST and ALT. However, remember that normal aminotransferase do not preclude cirrhosis, as level of these enzymes actually are dependent on functioning hepatocytes that are damaged. In patients with alcohol cirrhosis, gamma GT will also be elevated. With decompensation, bilirubin tend to drastically rise, causing jaundice. So, liver function tests are very important because they provide important information for grading the severity of liver disease. Their scoring systems such as Child-Pugh score or MELD score provide prognostic information, and it can influence the management of cirrhosis. Remember, in cirrhotic patients, hypoalbuminemia occurs due to impaired hepatic synthesis, increased albumin catabolism, and increased vascular leakage. So the coagulation factors 2, 7, 9, and 10 are synthesized within the hepatocytes. Cirrhosis impairs this production, so leading to increased prothrombin time. Patients who have cirrhosis with hepatic encephalopathy tend to have elevated ammonia level. As we have discussed that in patients with cirrhosis, the liver is unable to fully metabolize nitrogenous compound produced by intestinal bacteria, leading to its accumulation in the systemic circulation. Alpha-fetoprotein, well, it is a biomarker for hepatocellular carcinoma. Other causes of elevated alpha-fetoprotein include testicular cancer and germ cell tumor, and is not routinely used as a diagnostic or monitoring test, but as an adjunct to imaging. Hepatitis serology, well, it should be done in all patients with suspected liver disease to determine their infection and immunization status. Serology commonly tests for hepatitis A virus, hepatitis B virus, and hepatitis C virus. In patients with known chronic infection and on antiviral therapy, viral loads should be attained to determine the efficacy of treatments. So, this was all about investigations which are related to the pathology. So, moving on to our investigations, we want to do some imaging. So, in this patient, abdominal ultrasound reveals excessive fluid in the abdomen along with a large nodular liver. CT abdomen was used to assess for malignancy. A gastroscopy also reveals multiple varices along the patient's esophageal tract. So, as the patient was coagulopathic, a liver biopsy was contraindicated. So, remember, abdominal ultrasound, it is a first-line imaging technique due to its ease of access, safety profile, non-invasiveness, and low cost. Patients with cirrhosis will typically have hypoechoic nodules in liver parenchyma, and this may represent regenerative regions or small hepatomas. In some individuals, the liver may also be atrophied. CT, well, is not generally used during early cirrhosis as it is less sensitive than ultrasound. In established disease, however, it can be used to determine the extent of cirrhosis and screen for malignancy. Gastroscopy, well, is both diagnostic and therapeutic technique for the assessment of esophageal varices, which are common complications of portal hypertension from cirrhosis. Gastric varices may also be observed, although they are less prevalent. Liver biopsy, well, it is rarely performed unless clinicians are unable to determine a cause for the patient liver disease. Liver biopsies may also be used to determine the severity of cirrhosis, although imaging techniques like transient elastography, fibroscan are preferred. So, Peritoneocentesis were sent off for microscopy and culture. Wedge pressure were also considered once the patient was stable. So on discharge, he would require 6 monthly fibroscan to monitor the extent of his cirrhosis. So peritoneal taps, they are only conducted in patients with ascites. Fluid analysis may reveal an infection if leukocytes and bacteria are elevated, or malignancy if dysplastic cells are detected. So transient elastography, fibroscan, well, it is a cheap, safe and non-invasive technique used to monitor and measure the degree of liver fibrosis. And there are some limitations, which includes its inaccuracy in patients with ascites, obesity and concurrent hepatitis, and it is operator dependent. However, it is extensively used to monitor progression of fibrosis in patients with cirrhosis. So that's all about the investigations of the patient with cirrhosis. Now we come to the management part, and the management again will divide the management into the immediate management, the short term and long term. So this patient has presented with hematemesis. So after insertion of large bore cannulas, IV antibiotics were given, but not proton pump inhibitors were prescribed. A strict fluid balance chart and gentle albumin infusion was administered. To reduce the rate of active bleeding, splanchnic blood flow and portal hypertension were reduced with an octreotide infusion. An emergency endoscopy was also organized to confirm the presence of varices, which would require endoscopic banding. IV antibiotics, actually they are recommended for patients with hematemesis and cirrhosis due to reduce the risk of infection. Ceftriaxone IV is more commonly used, although ciprofloxacin IV can also be administered in patients allergic to beta-lactams. So once the patients are hemodynamically stable, switching to oral prophylaxis is recommended. Duration of prophylaxis is uncertain, although the shortest possible duration, 3 days, is recommended. And we should consider ceasing the antibiotics once bleeding has resolved and octreotide has been stopped. The use of PPI remains controversial, and they should not be routinely prescribed unless the patient is suspected to have active gastric ulcer bleeding. Because PPI, they have been associated with increased risk of spontaneous bacterial peritonitis, Clostridium difficile infection, and increased overall mortality. Fluid balance charts with urinary indwelling catheter insertion should be mandatory to assess the patient fluid status, especially if they are actively hemorrhaging or there is sequestration of fluids in the extravascular space due to low albumin. So a patient with cirrhosis suffer from hypoalbuminemia. Albumin infusions are necessary to maintain adequate perfusion, and this reduces the risk of renal impairment and mortality due to shock. So octreotide actually is a somatostatin analog, and that increases the vasoconstriction of the splanchnic arterial bed, reduces portal venous pressure, and reduces splanchnic blood flow. It also inhibits the release of glucagon, which is a splanchnic vasodilator. However, its effect on portal pressure is transient, and therefore it is used as an infusion. An alternative is terlipressin, a vasopressin analog. So in patients with active bleeding, gastroscopy will allow visualization of bleeding varices. Banding helps to control active bleeding, although sclerotherapy may also be employed in difficult cases. If bleeding remains uncontrolled, a temporary balloon tamponade may be inflated, which applies traction to the esophageal tract. However, remember, this is only a temporary measure, as esophageal necrosis may occur with prolonged inflation. A TIPS can then be performed to reduce portal hypertension. Okay. How about the short-term management? After the patient was stabilized, this patient has got ascites, so paracentesis was conducted to drain large volume of his ascitic fluid. He was also prescribed diuretics to reduce sodium renal retention. Lactulose was initiated with consideration of rifaximin if encephalopathy persisted. Replacement thiamine and vitamin B12 injection were also administered. So paracentesis is recommended in patients with large volume ascites for symptomatic improvement. A sample is also sent for microscopy, culture and sensitivity to exclude the spontaneous bacterial peritonitis. Albumin replacement therapy actually is recommended in patients undergoing paracentesis to prevent hypotension and prevent fluid shifts. Refractory ascites, it can be treated with repeat paracentesis or a percutaneous shunt between the hepatic and portal vein, which is called TIPS. Patients who are suspected to have subacute bacterial peritonitis should have their ascitic fluid drained, and they are empirically treated with ceftriaxone IV until culture and sensitivity becomes available. Antibiotic prophylaxis with trimethoprim sulfamethoxazole may be considered in patients at high risk of SBP, such as those with child poo score greater than 8. So remember, mild ascites, it can be treated with medications like spironolactone or amiloride, assuming that the renal function and the electrolyte functions are stable. These are actually aldosterone antagonists, and they prevent sodium retention, reducing fluid absorption in the distal tubules. Furosemide can be added for non-responder. Now, the lactulose therapy, it actually aims to reduce intestinal ammonia through multiple mechanisms. And the metabolism of lactulose to lactic acid by intestinal microbiota results in acidification of the gut and favoring conversion of ammonia to non-absorbable ammonium, effectively reducing the plasma ammonia levels and increasing its passage from tissues into the lumen. Rifaximin is an antibiotic only used in persistent and recurrent hepatic encephalopathy, and it reduces the level of intestinal ammonia producing bacteria. However, long-term use can predispose individuals to resistance. It is important to replace all vitamins such as thiamine and B12, and this can be done once patients are hemodynamically stable through intramuscular injections. B12 usually given IM and IV route for thiamine or oral supplementation. And this supplementation will help optimize medical function and prevent further deterioration in overall health. So this was the short-term measures. How about the long-term measures? The patient were advised to avoid hepatotoxin, cease alcohol intake, and begins IV drug rehabilitation. He was also encouraged to consume a high protein, low salt, high calorie diet. So a high protein, high calorie diet allows for maintenance of lean body mass and replacement of lost protein. We should consider referral to a dietitian to optimize the meal plans. Sodium restriction should also be encouraged to reduce fluid retention. A transjugular intrahepatic portosystemic shunt would also be available if his portal hypertension worsened. In order to be eligible for liver transplantation, the patient was advised to cease alcohol consumption and begin antiviral medication for his hepatitis C. He was also advised to regularly visit his GP and gastroenterologist for monitoring and screening of hepatocellular carcinoma and hepatorenal syndrome. So liver transplantation remains the only cure for liver cirrhosis. Native liver is removed and is replaced by a donor organ at a specialized hospital. Post-transplant immunosuppressive therapy will also be required to prevent organ rejection. Contraindications for liver transplant include advanced hepatocellular carcinoma or liver metastasis, uncontrolled viral hepatitis, active alcohol or substance abuse. So the risk of hepatocellular carcinoma is significantly increased in patients with cirrhosis, and this arises due to DNA alteration and mutation in the cells that allow it to replicate uncontrollably, and is the most common complication of cirrhosis. So screening through blood tests and repeat ultrasound every 6 months is recommended. If hepatocellular carcinoma detected, chemotherapy, percutaneous ablation, transarterial embolization, or surgical resection can be conducted. Liver transplantation should also be considered in patients with a single nodule. Finally, I'll want to talk a bit about the hepatorenal syndrome. So hepatorenal syndrome is a common complication of advanced liver disease, and it has poor prognosis. Pathophysiology is not well understood. It is thought to be secondary to portal hypertension. So what happens? The dilatation of the splenic vasculature reduces the circulatory volume and perfusion to the kidneys, and this activates the renin-angiotensin-aldosterone system, which causes vasoconstriction of the renal vasculature. However, this effect is insufficient to counteract the mediators of vasodilation in the splenic circulation, so leading to persistent renal hypoperfusion, aggravating kidney vasoconstriction, and leading to eventual renal failure. So dialysis, it can prevent further deterioration of renal function. However, liver transplantation is the only definitive therapy. So my dear doctors, that was all about the cirrhosis. Hopefully I have covered all the points. So as I have mentioned in my previous presentation, that this is only food of thoughts. Please continue reading the material, whatever is your reference material, and hopefully my presentation will help you in understanding the liver cirrhosis. Thank you very much, and I'll see you in my next presentation.